vascular disease mean something changed the neutral flow of the blood through the arteries and veins of the peripheral circulation. And mean the peripheral arteries mean arteries behind the aorta. If something behind the aorta, we call it the peripheral artery. And we are talking in particular arteries and veins in the legs. And actually, arteries and veins in the legs are more affected than the arms. And some patients, unfortunately, have both arterial system disorder and venous system disorder. So this is only a diagram. If we open the artery or the vein and we see inside the artery, we will have what we call it black formation, and you will hear this terminology frequently during the cardiology rotation. They are very, very important. Normally, the blood flow inside the arteries and veins is going smoothly. We call it laminar flow. Laminar, nothing interrupt the flow. But if there is what we call it black, and for the student, you have to know what are the risk factors to develop black. And basically, those risk factors including diabetes, hypertension, smoking, sedentary lifestyle, bad habits, and high cholesterol. Those clinical risk factors, we call it clinical risk factor, make the black, and the black will make the arteries narrower, and the patient will develop what we call it peripheral vascular disease. Peripheral vascular disease, in small and easy word, it is a narrowing of the artery. And if there is narrowing of the artery, there will be what we call it mismatch. Mismatch means the tissue needs blood supply, but there is no effective or there is no enough blood supply. So the patient, he will develop symptoms. And sometimes there is obstruction, complete obstruction of those arteries, so they call it what we call it gangrene or necrosis of the cells, because there is no enough blood supply reaching those cells and organs. And not all the time clinical risk factor. Sometimes the patient, he will have, for example, chemical or mechanical injury, for example, burn, or trauma, patient involved in a road traffic accident, or infection, for example, inflammation, and this in particular very, very important, vasospastic disorder and congenital malformation. So you have to put those in your mind when going to see your patient in the clinical practice. So back from the anatomy, this is the aorta, and there is more than one branches. I hope you can remember those branches. So anywhere can affect the disease, can involve any part of the aorta or behind through the aortic artery, femoral artery, popliteal artery, tibial artery, and perineal artery. So what are the risk factors? You have all the time to remember those risk factors because they are modifiable. Most of them, they are modifiable. What does that mean? That means as a physician, you can correct the disorder if you instruct the patient to behave or to control his risk factor. For example, diabetes, very, very common disorder, hyperlipidemia, hypertension, and in particular for peripheral vascular disease, nicotine usage, because it's very, very well linked with peripheral vascular disorder. And there are what we call it family. Some families, they have congenital, some have coronary artery disease and peripheral vascular disease, age, lack diet, and lack of exercise. Those are examples of clinical risk factors. As a student, we usually divide it to modifiable and non-modifiable risk factors. What are the non-modifiable risk factors? Anyone can answer? Age. You cannot change the age of the patient. Genetics, like family history, and gender, based on the three only non-modifiable risk factors. But all other are modifiable risk factors, so you can change it. So we as a physician, we put the efforts before the patient reaching the peripheral vascular disease to control those risk factors. And if you're going to see a patient with peripheral vascular disease, if you're going to examine his lips, there will be dry and it's shiny skin, loss of hair. This is very, very important, in particular in male. Nails thickened and ridged. Edema, in particular, very, very, very important. And gangrene. We don't want the patient to reach the gangrene, and we have to control all the risk factors before the patient reaching the gangrene and necrosis and the tissue. So how we can ask the patient to assess him if he has peripheral vascular disease? Simply, we will ask about the symptoms. And what are the most common symptoms the patient present to you in peripheral vascular disease? If there is no effective blood supply to the lower limbs, what the patient will complain of what? Pain. When he walk, he will develop pain, and we call it as a medical terminology claudication. This is very, very, very important. Very, very important. And not most of the patients, they think they are tired because they are obese, they are all elderly. They think this is claudication. So you have to ask him in particular. Mr. Ahmad or something, when you walk, you have pain in the lower limbs. If he has risk factor, he said yes, and you have to do more further assessment. So ischemic muscles ache or pain that is precipitated by constant level of exercise, especially patients who are walking, for example, to the mosque or in the mall or anywhere. So you have to ask him in particular how many meters you can walk until you have this pain. So this is to reflect this severity of disorder. Okay? And sometimes the pain in the forefoot at rest, they call it rest pain, and this reflects severe arterial insufficiency. And if the pain relief put the extremity in dependent position like this, the patient he will go. And most of the time it occurs at night. So this is the typical symptoms in patients with the claudication. This is very, very, very important for you as a clinical background. And for physician, we do examine the pulses in all patients with suspected or confirmed peripheral vascular disease. And diminished or absent pulses, this is by itself is a clinical scenario or a clinical diagnosis of peripheral vascular disease. And sometimes we use Doppler. Doppler, this is what we call it ultrasound study. We put ultrasound wave in the artery so we can measure the velocity of the blood. If it is diminished, that means the patient has peripheral vascular disease. Paresthesia, some patients, they present with pain. They say, doctor, I have pain, burning pain in the extremity, present, and sometimes the pain developed in the ulcerated area. So the patient will come to see you because of this pain and produce less of pressure and deep pain sensation, and injuries often unnoticed by the patient because some patients, they have combined neurological problem and vascular problem. So if they have a wound, they will not feel it. So he said, this is normal, doctor. Why you are concerned? This is totally abnormal. And what are the complications of peripheral vascular disease? Atrophy of the skin and underlying muscle. Delayed wound healing. And this is a problem. And if the patient has, for example, wound, and this wound got infected, if not treated well, it will be ended by what we call it amputation. And we don't want this to happen to our patient. Tissue necrosis, arterial ulceration. There is two types of ulcers. There is what we call it arterial ulcers and venous ulcer. And at the end, the amputation is the most feared complication, and we try to prevent from skin until the disease reaching the deep tissue by preventing the risk factor. So this is example of amputation. Amputation means cut. For those who don't know the terminology, we cut the necrotic tissue. We get rid of it. Why? Because if there is infection in this tissue, it will spread. Because even the antibiotics will not reach this dead tissue. There is no vascular. So the antibiotic will not reach. So the solution, we get rid of this necrotic dead tissue, and of course we don't want this picture in the clinical practice. We need to prevent. I'm repeating this again and again. So how we can do clinical diagnosis, how we can confirm this diagnosis, we do what we call it, this is very, very important for the medical student. So what we call it, ankle breaker index. And what does that mean simply? As a rule in cardiovascular diseases, there is what we call it pressure. So the pressure must be equal in the upper limb and in the lower limbs. And we accept some variation. For example, in the upper limb, the pressure is 120/80. In the lower limb, we accept like 10-15% change, no problem. But if more than that, that means there is something wrong in the peripheral artery, and in the pressure in the lower limbs going less than upper limbs. Okay, so what we put, we measure the pressure in the upper limb and in the lower limb, and we do what we call it ankle breaker index. We divide both of them بعدين تطلع النتيجة. If the less than 0.7, that means it is positive test, and this is a definition of peripheral arterial disorder. This is very, very important. We do it sometimes the patient is resting, and sometimes we ask the patient to do exercise, and we do it while exercise. So this is very, very important. This is what we call it rest, at rest. So if the patient has more disorder, you got the idea? The idea, if the patient has narrowing in the lower limbs, the pressure, it will be less than the upper limbs. Okay? This, for example, in the upper limbs 120, it will be down in the lower limbs, for example, 90/50. So this is huge variation. That means there is something wrong inside the arteries in the lower limb and make the blood pressure lower. Clear? So the concept is very, very easy. And sometimes we use this machine. This is ultrasound machine. We put it inside. Of course, we know the anatomy. We put it on the vascular system, and we measure the velocity of the blood. If the velocity of the blood got diminished, that means, of course, there is something wrong in those arteries, and this is also a clinical definition of peripheral vascular disease. Nowadays, those, هذا عشان very important. The nursing in the morning, the nurses they do this for us, for better assessment and control of the disorder. And sometimes the scenario is more difficult. Still, we have no clear diagnosis. So what we do CT. CT, one kind of the radiological test. Okay, and we do for this patient CT study to assess the peripheral vascular disorder. And sometimes the scenario is more difficult. You know CT, the terminology. It is part of the radiological study to assess the peripheral vascular disease. Of course, there is more than one usage of the CT. And sometimes we do angiogram. And angiogram, you have to know this terminology now. Angiogram, we inject iodine material inside the artery, and immediately we do what we call it fluoroscopy or X-ray on the patient. And we can see by our eyes the peripheral vascular disease. This is, we call it invasive study. Invasive means we put something inside the patient's body. So this is the gold standard of diagnosis of peripheral vascular disease. And we can also define the disorder, and at the same time we can treat it. And if we're going to see inside the artery, they will have what we call it here. This is the normal. Inside, if we do angiogram, we can see this is normal artery. Of course, there is no stenosis here, RBCs is traveling down normally, no problem. But if the patient he has the risk factor, there is what we call it narrowing, and we can see this clearly when we do angiogram or angiography. And sometimes the patient he has completely blocked artery. And as a medical student, what do you think if the patient has completely blocked artery? What will happen to the patient? Anyone? Ischemia, yes. You can divide it better into categories. Is it acute occlusion or it is a chronic? If there is acute, the patient he will come to you shouting of the vein because he has acute. You have to you have to understand things in two scenarios. Is it acute or chronic? All disorder. So acute, the patient will come to you shouting from the vein, and because he has what we call it life-threatening disorder, and he is going to lose his limbs. He has severe pain. And if it is a chronic like this, most of our patients they are chronic because they have risk factors. So what will happen? Of course, he has a pain, but okay. So what we call there is something we call it collaterals. Collaterals mean formation of a new arterial system. يعني كأنه يحاول ينقذ الموضوع يعني. So there is collateral. So start here. The arteries generate new arteries, small, tiny arteries, just to make the reperfusion to the tissue. But this will not be enough to the tissue to have oxygenation. So prevention all the time. We put all the efforts to prevent this disorder, as I said. And most of the patients, they have high cholesterol, smoker, and other clinical risk factor. Clinical risk factor, as a medical student, you have to know in details. Okay. So as a management, we correct risk factor if the patient has disorder or evidence of atherosclerosis, control hypertension, exercise, nicotine. He has to stop nicotine. Medication to lower the blood lipids, for example, statin. You will take this in details in pharmacology lecture. And sometimes we send the patient for surgery. And believe me, the surgical correction of the arterial system is a major surgery. It has very high risk of complication. So as I said, we can use angiogram as a diagnosis and as a treatment. So if we find during the angiography, this scenario, almost totally blocked artery, we can put a stent. And you're going to hear this terminology in the cardiology frequently. And what the stent means? The stent is like this. It's like a network or the stent. We put it inside the artery to make it wider. So we call it PTCA, percutaneous coronary intervention, or arterial intervention. So this is as a simple clinical information in peripheral vascular disease. Now we have other scenario. For example, if the patient has, this is another cause of peripheral vascular disease, what we call it arterial thrombosis. So for example, patient he has no diabetes, no hypertension, he's not a smoker, but he's coming with peripheral vascular disease. That means either this patient has thrombosis inside his artery, and we're going to discuss this in details in DVT lecture. And why? Because some patients, they have what we call it hypercoagulable state. They are prone to thrombosis. Why? Because there's something wrong inside the intrinsic and extrinsic pathway اللي خدتوه في pharmacology. So they have this problem, and sometimes they have spontaneous arterial occlusion without any notification. So and sometimes the patient will have embolism. Embolism means thrombus formed somewhere and was sent by arterial system to other artery. For example, if the patient has left ventricular thrombus, for example, as a complication of MI, for example, this thrombus can travel to block any artery inside the body, including peripheral vascular system. So those are two entities of peripheral vascular disease. We call it arterial thrombosis because the patient has hypercoagulable state, and sometimes there is embolism. You have لازم تفرقوا بينهم. You have to know both of them. And this is another entity. This is very important for medical students. ليش؟ لأنه تيجي منه أسئلة. So what we call it Berger's disease. أكيد حتاخذون إن شاء الله during histopathology because it has very interesting histopathology pictures. So what Berger's disease? It is inflammatory changes in both arteries and veins. If you notice in the beginning of the lecture, we said sometimes the inflammation can lead to thrombosis. And this actually happened in this disorder. It's very bad disorder, and the patient can suffer from this. And this inflammation, and what a line here, it is inflammatory disorder. It is not plaque rupture, it is not thrombosis, it is not embolism, it is inflammation of the arterial system. And this inflammation results in destruction of small and medium vessels. This is, again, it's very, very particular. Is it a disease of the large arteries? Like aorta? No. This is not a disease of the large arteries. It's a disease of the small and medium arteries or vessels. Usually affect lower extremities but can also seen in the upper extremities. So the etiology, most of the time, it is unknown, but it is linked, very well linked with the cigarette smoking, and nobody knows why the cigarette smoking can provoke inflammatory changes inside the artery, not yet. Non-tobacco use, of course, linked with the Berger disease. If you hear Berger disorder, immediately think about smoking, and you have to ask the patient about smoking history. So inflammatory process damages the blood vessel wall, and in the histopathology, there is lymphocyte and giant cells infiltrate the vessel wall with fibroblast proliferation. If we have biopsy means we have a cut from the arterial wall, and we examine this biopsy inside the microscope. You will have very, very specific histopathological feature for Berger disorder. And because there is inflammation, because if there is inflammation, there will be thrombosis and fibrosis occurs in the vessel causing tissue ischemia. And most of the Berger disorder patient, they have this black color mean gangrene, already dead tissue. Why? Because inside this finger, there is very diseased arterial system. And this very diseased arterial system cannot provide oxygenation for this tissue, so the patient, he will have necrosis and death of the tissue. Sorry? Berger disorder is very difficult to manage because if we cut those fingers, the patient, he will have again necrosis in other parts. So we try to treat the cause. We give them anti-inflammatory, and sometimes what we call it antiplatelet, like aspirin, and anticoagulant, and we try to control risk factor. Why? Because if you cut the fingers and the patient continues to smoke, he will come back to you again with other necrosis and gangrene. And it is particular disease of the male. Most of the patients, they are males and they are cigarette smoker. Most of them. And the age between 20 and 40. Small incidence, very, very tiny percentage that will happen in the female. And most of the time is linked to the tobacco use. Sinus symptoms, as any peripheral vascular disease, the patient, he will have pain, loss of hair, edema, ulcers, and other clinical picture. We'll discuss it in the beginning. So the pain, as I said before, it occurs in the feet, especially the arches or legs after exercise. So you have to ask the patient, when you walk, you will have pain. And sometimes there is ulceration. So ulcers is very, very, very common presentation in Berger disorder. So they have ulcer. Why ulcer? Because there is less blood supply, so the tissue will start to have necrosis and ulcer. Now we'll come to the last disorder as a peripheral vascular disease. We call it Raynaud's phenomenon. And this is very, very, very common in female in particular. Okay? And this is why female patients they have Raynaud's phenomena. You heard about Raynaud's phenomena before? Yes. Okay. So it's characterized by vasospasm. Vasospasm means transient occlusion or stenosis of the arteries and arterioles. Arterioles means small, tiny arteries. We call it arterioles of the upper and lower extremity. And this is very common in females. Why? Because there is vasospasm of the arteries and arterioles, and there will be change in the color of the fingers. And if you notice this, so this is normal color, but here there is abnormal, there is white color here. So this patient might have what we call it Raynaud's phenomenon. Is it bad disorder or not bad disorder? Sorry? Not bad. It's only for color changes, but it is actually not bad. Sometimes it's idiopathic Raynaud's phenomenon, and sometimes what we call it Raynaud's disease occurs in absence of underlying disorder if the patient has no clinical risk factor. And secondary Raynaud's phenomena if the patient has coronary risk factor or peripheral vascular disease, and it's very, very, very well linked or associated with connective tissue disorder. And connective tissue disorder all the time is linked with peripheral vascular disease or cardiac disease. Why? Because they have that same problem. There is inflammation inside the arteries. Usually connective tissue disorder like systemic lupus, rheumatoid arthritis, and scleroderma. So clinical manifestation of the Raynaud's phenomena or Raynaud's disorder, it is change of the skin color. Change of the skin color. So the patient will come to see you because, doctor, I have a change. All of a sudden, the patient he will have or she will have change in her fingers. So the color changes in the Raynaud's phenomena are characterized by a sequence of color change. Sometimes it is blue, sometimes it is white, sometimes it is red, and sometimes the patient will have numbness, tingling, and burning pain at the site of this change of the color. And sometimes it's bilateral in both hands, sometimes it's unilateral, so there is no rule to follow in Raynaud's disorder. So, how we can manage this patient with Raynaud's disorder? We try to control risk factor. For example, tobacco, if the patient is using nicotine substance, we'll ask them to stop. And cold. Some patient, when she's in cold place like this, the patient she will have Raynaud's disease. And in particular, calcium channel blocker can help because some patients she will have more frequent symptoms. So we can help the patient by giving them what we call it calcium channel blocker. And the idea behind the calcium channel blocker is vasodilatation, because actually calcium channel blocker, the action of calcium channel blocker can give vasodilatation. So we do this for this patient and can relieve the symptoms. And sometimes not working, so ask the patient to wear gloves and avoid touching cold items. Sorry?
This slide, it says that the color change can be white, blue, or red.
Yes.
So I don't get how come the red, although we have the decrease in the
Because as a response, it's hyperemia.
So sometimes, this is a good question, sometimes the color changes from white to blue to red. Why red? Because there is what we call it hyperemia as a response of the body. Because this patient arterial system is intact. She has no blood. So as a result of this disorder, sometimes the patient becomes as red. Why? Because hyperemia, more blood supply is going toward this finger, and the patient she will have actually there is no rule in rhinoid phenomena. No rule. Some patients they present with, most of the patients they present as a white finger, and some of them they present with blue, and some of them present with red. In clinical practice, we cannot predict the color for the patient. Like at least we can make a diagnosis and ask the patient to control risk factor. We can give them calcium channel blocker, and if not working, we ask them just to put a gloves. So Raynaud's phenomena is not really bad disorder. You can call it cosmetic disorder, but it is very what you really need to know about the Raynaud's phenomena. It's very well linked with the connective tissue disorder. And in cardiology block, you will hear the terminology of connective tissue disorder frequently, because patients with connective tissue disorder they are prone to complication because they have inflammation of the arteries. So they have patients with connective disorder they have high risk for peripheral vascular disease and cardiac disease. So this is all what you need to know about peripheral vascular disease. I hope it is easy, and if you have any question, we can discuss it. Now we'll come to the aortic disorder and the peripheral vascular disease. So back from the anatomy, aorta, I hope you can remember the aorta. There is ascending and there is descending aorta. Ascending means the aorta coming out immediately from the heart, from the left ventricle, after the aortic valve, and descending aorta, both ascending aorta will discuss a specific disorder, and descending aorta will discuss a specific disorder. So those are the goals of this lecture. Aortic disorder is very important, and we'll go and discuss those goals. So aortic aneurysm. We have two disorders here. We have aneurysm and we have dissection. So which one is more serious? Aneurysm? Dissection. Dissection means there's something major change inside the aortic wall, and this dissection leads to serious complication and maybe sudden death. But aneurysm is more like a chronic disorder. Okay, and aneurysm is defined as pathological dilatation of the segment of the blood vessels. And we have true aneurysm and we have pseudo-aneurysm. True aneurysm involves all the three layers of the vascular system, and pseudo-aneurysm, in which the intimal and medial layers are disrupted and dilatation is lined by adventitia. So we have true aneurysm, we have pseudo-aneurysm. Those it will be covered in details in anatomy classes. Aneurysm also can be classified according to their gross appearance. So this is as what we call it histological classification. It is true and false. And sometimes we classify it as a fusiform aneurysm and saccular aneurysm. And fusiform aneurysm affects the entire circumference of the segment of the vessels, resulting in diffusely dilated artery. Saccular aneurysm involves only the portion of the circumference, resulting in outwatching of the vascular wall. So this is only as classification of the aortic aneurysm. Most of the time we go with the true and pseudo-aneurysm. It's better clinical-wise. And this is an example of fusiform aneurysm and saccular aneurysm. Can affect ascending aorta or descending aorta. And sometimes we classify the disorder as abdominal versus thoracic. In other words, ascending and descending aorta. Descending means abdominal. So what are the etiology of the aortic disorder? Sometimes a degeneration of the vascular system, atherosclerosis in particular, inherited, this is very, very, very important, inherited like Marfan syndrome. If you're going to see a patient with Marfan syndrome, we have to examine his aorta. We have to examine his aorta. And sometimes aorta is like any other organ in the body. It can get infected, so we call it infectious causes. And vasculitis. Vasculitis means connective tissue disorder. There is inflammation of the, there is autoimmune disorder, and there is inflammation inside the aorta. And sometimes trauma can make aneurysm, or pseudoaneurysm, or even aortic dissection. And sometimes this is idiopathic. There is no cause, just the patient got aortic disorder. So we'll come to the most important etiology, like degenerative aortic aneurysm. And when you're going to read this at home, you have to pay attention to the differences between them. And here الأسئلة. Okay? So inflammation and biomarker wall stress contribute to the degeneration process that characterize most aneurysm of the abdominal. So is it abdominal and descending aorta? So it is more in abdominal, so the degeneration. These are mediated by B and T lymphocyte. This is as a pathophysiology of the degenerative cause. We are talking about causes now of aorta. One of the causes is degenerative, and those are the causes of the degeneration and the location. And other, what we call it, collagen disorder like IHDAR, and for example, patient also hypertension, congenital bicuspid valve. This is very important clinical practice. Why? Because the aortic valve usually it is tricuspid. And if the patient has bi means two, this is when this disorder is linked to the aortic disorder. And familial thoracic aneurysm syndrome. So all those are very, very important, and those patients, they will suffer from degenerative cause or cystic medial necrosis cause. Yes, exactly. Other causes of the aortic aneurysm, for example, vasculitis, and you will hear this terminology and again. Spondyloarthropathy, this you will take it in rheumatology classes. This is part of the connective tissue disorder. So to make it easy, any connective tissue disorder can lead to aortic disorder, including aortic aneurysm and more serious as a dissection. So third cause of aortic aneurysm is infectious cause. So the aorta, as any other organ in the body, can get infected. Okay, and previously there was what we call it syphilis. And syphilis can affect the aorta and can give aortic aneurysm. And again, where is the location? It is proximal, ascending aorta or aortic arch. All the time, aorta, دائما think about the location. All the time think about the location of the disorder. Traumatic injury, especially particular, very, very important, patient involved in RTA, road traffic accident. So they will come to ER, you have to think deep inside the patient body. So think about the aorta. Okay? May occur after chest trauma, or most frequently the location is descending thoracic aorta, just behind the site of the insertion of ligamentum arteriosus. Why? Because there is what we call it mechanical or mechanism of injury. Most of the time involve the descending aorta. Descending aorta. Why? Because thoracic aorta is protected by ribs, but the descending aorta is not. So traumatic injury is very, 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 very important. Now we'll come to the most serious disorder. It's like acute disorder. So we call it, what does that mean? That means it is life-threatening disorder. You have to make a diagnosis immediately. You have to think about it immediately. And this is aortic dissection. Dissection means like a cut. Okay? It's caused by circumferential or less frequently transverse tear of the angina. It often occurs along the right lateral wall of the ascending aorta where the hydraulic shear tears is high. Yani those information is very important. You can make it what is the most common, what is the location most common, so we can make some questions. Another common site is descending aorta just behind the ligamentum anterior. So those are the common site. Why we call it common? Because if we go and examine the patient, we have to pay attention to those locations. Okay? And this is an example of the aortic dissection. So there is blood flow here, it's going laminar, it's going smooth. Then there is what we call it aortic dissection. So think about it as a medical student. There is here two flow. There is one flow here where is the resistance is low, and there is flow here where is the resistance is high. Resistance means pressure. So the pressure here is 120 over 80, for example. But here is very low. So the blood flow will prefer which place? This one or this one?
No.
Yes, because there is less. So if you don't stop this disorder, the tear will continue. And what will happen if they continue? For example, if there is here renal artery, what will happen to the renal artery? Yes, it will be blocked, or there is interruption of the blood flow. And at the end, there will be what we call it aortic rupture. So it is very, very serious disorder. Very, very serious disorder. You have to think about it immediately. So the patient clinically, so you have to listen to this. The patient comes to see you because he has acute tearing chest pain. Okay? And this pain, pay attention to those information, radiate to the back. So the patient, he will tell you, doctor, I have chest pain and the pain is tearing. Tearing means very, very severe. And radiate to the back. So immediately put in your mind aortic dissection. And immediately start investigation and management. So is it important to know which one is what we call it? This is we call it true. This is we call it true, and this is false. Because if we come and we put a stent here, we have to put it in the true lumen, not in the false lumen. لو حطيناه هنا حيكون في sudden aortic rupture and death. So we have to put the treatment or the stent here in the true lumen. Okay? So we have to know the complications.
So if that's happening in the abdominal aorta, the vein will also be in the chest area?
No, and the abdominal aorta will be in abdomen, but aortic dissection more common in the thoracic. So the patient he will have acute tearing chest pain radiate to the back. So if the patient has continued the dissection continue, he will have limitation of blood flow for a vital organ, for example, upper limb, lower limb, the kidney, intestine, stomach, and there is what we call it a thrombus formation. It's called a thrombus here because the blood flow got interrupted. So how we do this? How we can suspect this clinically? Aortic dissection, the pulsatile aortic flow dissect along, as I said, the elastic laminar plate of the aorta, like this scenario. So this will dissect the vascular wall or aortic wall, and usually it starts proximal and propagate distally, and يبدأ in thoracic and can continue down to the abdominal aorta. So the symptoms. The patient will have chest pain, the most common symptoms. Loss of the pulses. For example, if the patient has aortic dissection, and this dissection involves the blood supply to the arm, so if you put your hand here, you will have no pulse. The patient has no pulse. And unequal blood pressure. If the patient has, for example, dissection in the left arm, So you measure the blood pressure, it will be low, but in the right it will be okay. So this means dissection. And this is an example of dissection. Start proximal, then there's dissection. All this is false lumen. So all this will propagate distally until the patient will have. And sometimes there will be thrombosis here. As a classification, we classify those patients to, there is two common classification system. One is Stanford, one is DeBakey. It is type A and type B. Not very important for medical student. We use this classification as a management, as a vascular surgical consultation. If we need to go for surgery, we have to know which type. Is it type A or type B? Is it DeBakey type 1, 2, and 3? So type 1, here is type 1. The easiest classification is DeBakey. In 4, the ascending to the descending aorta. So it's very severe. So here the dissection starts. So if the patient has complication of this artery, what will happen to the patient? Which artery is this? So what will happen to the patient? He will have. So the blood interrupted from brachiocephalic, the patient he will have?
Brain.
Yes, he will have stroke. And if the patient has interruption of the carotid artery, he will have dissection and he has a stroke also. And if the patient has what we call a extremity vascular system, this one, he will have dissection of the blood supply of the left arm, and you will have severe pain inside the left arm and continue like this. Type 2 dissection is limited to the ascending or transfer aorta without descending, and type 3 is dissection involving the descending aorta only. Why this classification? It is a surgical classification. ليش؟ لأن if the surgeon he wants to go and treat, he has to know which type. وإلا ما حيقدر يعالج. He will not do anything. And this is another example of aortic dissection. This is what we call it sinus of Valsalva, and this is the aortic root. This is the coronary artery. And imagine if the dissection starts proximal to the coronary artery, what will happen to the coronary artery? Got what? Block, and with the patient he will have ischemia inside his heart, and he will have myocardial infarction. And this is one cause of ST segment elevation MI or myocardial infarction is the aortic dissection. And this scenario is very common in the pregnant lady. I'm thinking. Sorry, the lecture today is very huge and there is a lot of information, but we have to cover it all. Any questions? You have the slide.